Good afternoon, friends, respected seniors, and respected dignitaries on the dais. I'm going to talk on fear of cloudy cornea, cataract in presence of endothelial dystrophy. Cloudy cornea gives a major challenge preoperatively, intraoperatively, and postoperatively to a cataract surgeon. The major difficulty is a clear view through the cornea to the lens. Cornea endothelial dystrophies are one of the most common ocular comorbidities that we come across while seeing cataract patients, and it can be a source of frustration for both the surgeon and patient, increases the risk of intraoperative complication, and impacts the final visual outcome. There can be various causes of endothelial dysfunction, right from Fuchs endothelial corneal dystrophy, posterior polymorphous corneal dystrophy, eye syndrome, trauma, infectious endothelitis, Axenfeld Rieger's anomaly, and previous glaucoma surgery. Just a quick recap of these dystrophies. We know Fuchs is a bilateral, slowly progressive endothelial cell density. There is a decline in endothelial cell density, and there is a characteristic gutta formations. In posterior polymorphous corneal dystrophy, there is characteristic snail track appearance, and it's a non-progressive condition. Eye syndrome, among the three entities, Sandler's syndrome has corneal signs predominantly with a characteristic hammered silver appearance on slit lamp by a microscopy. Viral endothelitis can lead to cataract formation and irreversible endothelial decompensation requiring surgical intervention. Trauma, we all know, can cause endothelial damage, subsequent cataract formation, and corneal opacification. When such patients come along with cataract, the biggest question is, what is the risk of corneal decompensation? Whether we should go only with cataract surgery or it has to be combined with endothelial keratoplasty. So before deciding the type of surgery, we should be aware that what are the risk factors for corneal decompensation after cataract surgery. So patients with obvious corneal edema or bullae, increased corneal thickness which is more than 650 microns, confluent guttatae, blurred vision and glare which is worse in the morning, and specular microscopy showing low endothelial cell count which is less than 1000 cells per square millimeter. There are various techniques to evaluate corneal endothelium. If we do specular microscopy, it is useful only in cases where there are fewer non-confluent and discrete guttata. But always keep in mind that early or late corneal decompensation will be there if central endothelial cell density is less than 1000 cells per square millimeter. It is not of much use if there are numerous guttata and in presence of corneal edema. Confocal microscopy can be useful in corneal edema patients, but it is of not much use nowadays. Corneal thickness measurement, which can be done with ultrasound pachymetry or anterior segment OCT, shows that when the central corneal thickness is more than 700 microns, it is indicative of endothelial decompensation. The most important thing is that we should take an average 3 central pachymetry measurements at each visit to overcome physician and technician variability. Before finalizing the type of surgery, we should always keep in mind that cataract surgery alone will decrease endothelial cell density by 1.8 to 15%. So in a compromised endothelium, this decrease may be further accentuated and there can be a persistent postoperative edema 4 times higher. Though triple procedure is a single procedure, the advantage is that, but there is always a possibility of higher complications. Finally, the patient's visual need and expectations should be considered, and both surgeon and patient should be mutually satisfied with the selected surgical plan. As far as the choice of surgery is concerned, when we are doing a cataract surgery alone, we can do phaco or small incision cataract surgery in cases where there is mild endothelial compromise and patient is not healthy to tolerate a prolonged procedure. With severe corneal edema, definitely when the view is not clear, we have to either go for a triple or a staged procedure. Now, this is a video of a patient with early cataract endothelial cell loss and Fuchs corneal endothelial dystrophy. In this patient, only cataract surgery was done. So certain tips we should keep in mind while doing cataract surgery in such patients is sharp instruments should be minimally used. We should avoid contact of instruments with the corneal endothelium. Anterior chamber should be adequately maintained throughout the procedure. While doing the nucleus delivery, soft cell technique of using viscoelastic, that is, a dispersive viscoelastic should be used to cover the corneal endothelium, and below it a cohesive viscoelastic should be used. For phacoemulsification, low power is always advised. Phaco chop technique and use of oscillatory handpiece is always recommended. Use of viscoelastic during phacoemulsification will be beneficial for the patient. As far as irrigating solution is concerned, Ringer's lactate is commonly used, but it is suggested that balanced salt solution should be used as it has glutathione and it gives a more physiologic environment. While implanting the IOL, the reverse soft cell technique should be used. A thorough AC wash is a must because remaining fragments can lead to raised intraocular pressure and subsequent endothelial decompensation. This is a video of a patient who had severe corneal edema and we had done triple procedure. Now as we can see here, initially the corneal epithelium was removed with the use of a cotton tip applicator. Where the view of the anterior chamber is hazy, it is recommended to use trypan blue for capsulorhexis. After completing the capsulorhexis and doing sufficient hydrodissection, the phaco technique, as I advised in the earlier surgery, should be maintained. At any point of time, anterior chamber should be maintained using the soft cell technique. Repeated use of viscoelastics during phacoemulsification is highly recommended. Now, once the irrigation aspiration is completed, a thorough AC wash is done and IOL is implanted. After IOL implantation, the recipient's Descemet membrane and corneal endothelium is removed and it is taken out from the main entry. Subsequent AC wash should be done so that there is no remaining viscoelastic. The pupil is myosed and donor graft tissue is inserted into the anterior chamber. There are certain points, as you must have seen, that the donor graft was scrolled upwards. That is, the endothelium should be facing outward and there should be proper orientation of the graft. Tapping on the anterior corneal epithelium will help to stabilize the graft and help in proper positioning. Once we are ensured that there is proper position, we can fill the anterior chamber with air and ensure that the graft is in position. Suturing of the main entry wound is recommended so that there is no collapse of anterior chamber. Now this is a photograph of a patient in whom we have done triple procedure using DMAC. We can see in the post-operative photograph an inferior peripheral iridotomy has been done. This is a must in a combined procedure case to avoid pupillary block. Certain important considerations while handling such cases: if we are finding difficulty in biometry, we can always take an average K reading or we can take keratometry from the fellow eye. 3-piece IOL is strongly considered, and in cases where the anterior chamber depth is less, we should always perform EK first. Choice of surgically, as I said, it depends on the density of cataract and surgeon's experience. Viscoelastic, I already mentioned. Irrigating solution, I mentioned. Placing a suture would be better. Post-operative, patient may need frequent steroids and hypertonic saline, and periodic follow-up is recommended. So the take-home message is, in cases of combined surgery, when CCT is greater than 640 micrometers, endothelial cells are fewer than 1000 cells per square millimeter, and there is microcystic edema, we should always go for combined surgery. Choice will depend on surgeon's experience, and when doing phaco, we should have advanced phacoparometers, phaco-chop, soft cell technique, and use of torsional phaco tip is advocated. Thank you so much.